like a iliac crest, axial, some sort of mechanical neuropathic, above iliac crest pain or around this area, superior cluneal, sacroiliac gluteal pain, you can think about middle cluneal nerves, knee pain, like very common in your practice, the infrapatellar saphenous or the inferior genicular, ankle, foot, peripheral neuropathy, posterior tibial nerves. So those 5 nerves, when you look to your practice, I mean, this is a big part of your practice, and you can do it only with X-ray. From here, sorry. The wearable. Seriously, when we thought about like an external wearable device, a lot of patients and even a lot of physicians, they were like skeptical. How like you will convince the patient that they have an external wearable device each time the patient have to use the device. You have to have an external wearable. But the patient accepted very well. And they came even recently for the last 3-4 years with a lot of customized, very actually elegant and very stylish wearable. Before they were like struggling a little bit, buying from Amazon, buying from here, they customize it, they cut it by themselves. But now they have a contract with a company, and they do very well designed, elegant, and you can wear it over the clothes. Even the patient tolerate it very well, very acceptable.
The Lululemon one?
Yes. So
That
this
was
is
part of the early days from Amazon.
the torso belt, and then this is the extremity wearable.
And actually, the rep work as a designer at that time, like you were like
I did.
Yeah.
Courtney and I did.
design.
Yes. And then the little transmitter can fit into the pouch, so at night they don't really see it flashing through here, so it's not like keeping them up. And then there's a little cage that goes on side the transmitter, so they don't accidentally like bump it and turn it off. So it's the wearables.
And all of you saw like the neuromodulation with a spinal cord stimulator. Like a lot of patients, they don't need to stimulate the nerve, spinal cord or peripheral 24/7 for years. And maybe one of the reasons of the habituation or loss of efficacy, and that we don't know like how much energy we really deliver. We don't know how much energy the nerve needed to treat the pain. So 24/7 you are bombarded the nerves, bombarding the spinal cord stimulator with like tons of electricity that change significantly with position. I mean, there's like, as you know, data with the spinal cord stimulator. Imagine even the peripheral nerve stimulator. We're bombarding the peripheral nerves 24/7, maybe unnecessarily, with tons of electricity. We don't know what the nerve response, how much we need, how much. So it's too much. The patient, a lot of times, the majority of the patient actually, they use it not every day. They use it like 3-4 hours every 3-4 days or so. They put it in, after hour 2 they feel better, they keep it for 3-4 hours, they sleep, or they're sitting at home, and then just take it off. They feel better for a couple of days or 3 days, and then when it starts to feel back pain, they put it back again. So when you this is what the patient needs. Each patient needs different than anybody else. And also one important thing that with the peripheral nerve, that's different than the spinal cord stimulated, that the distance from your lead to the nerve, you work hard to put it close to the nerve, and you check this with ultrasound and X-ray that you are close to the nerve. But a lot of those targets, I guarantee you, the minute that the patient walk, the minute that the patient go from the OR table to the vacuum, the distance will change. And month after month, the distance will change with each movement. Because it's not like an epidural space. The distance from your epidural space to the dorsal column is X, and even with the movement, it will change, but it will change limited. The peripheral, it will change a lot. Whatever you tried, unless you are through the paraneural connective tissue, and you are really very close to the fascicle, so whatever the nerve will move, the lead will move with it. But usually you are above this paraneural connective tissue, so it will move. So the amount of energy will change significantly with the movement, with scarring, with time. So the needs of the patient will change because of this. And also the pathology itself will change. So all the patient doesn't need to use it that much.
Why don't they put the 8 leads instead of the 4 for the implant?
Very good, because this will increase your area that you're covering.
And with the movement, you can capture them.
The 8 leads, they have 8 leads, and you can implant the 8 leads.
Oh, you can? Okay.
But it's not MRI condition, so they didn't test it for that condition, and also doesn't have tines.
So it can.
So it moves more, and the patient cannot have MRI. So you can implant permanently the 8. Let's say you have a patient like very old or close to be terminal, or you don't think that he will need an MRIs.
I put the
Just put the 8, but the migration will be higher a little bit with no tines. Ideally, if they have 8 with tines and MRI condition. Let this question
In the works, with R&D,
with that. Okay.
it's in the works.
in the pipes. So.
In the pipes. The one worry I think was with the tines being back here and your contact being over here is how are we gonna stabilize this end? This end is gonna stay.
It's too long.
What are we gonna do over here with this? So that's was the difficult part about getting an 8 with time. But we offer it, and like you mentioned, it loses its MRI conditions, no tines.
Yeah. I mean, there is one lead that have proximal and distal tines. The reactivate.
Oh, yes.
Yeah, the multifidus stimulator.
Right.
It have tines proximally and distally. So distal to the contact and proximal, so it prevents proximal and distal migration. But this is just designed only for the multifidus. For the peripheral, it may be challenging. Like technically, when you put it in the target, also they have time distally.
Yeah.
Just like a different animal, I can say that. So this is kind of the wearable. So they have different design. I think okay. It's like, for example, the cluneal, or you can use it for the suprascapular. We'll talk about the 5 core nerves. It's indicated only for adults. It's not approved for kids. Maybe just off-label if you have a kid, use it in. And the contraindication, just the general contraindication for any surgical procedure, surgical risk, pregnancy. I mean, it's not tested. I mean, I cannot see it as like a absolute contraindication. But definitely, I mean, very rare situation you want to implant a PNS in pregnant patient. And that's why also the patient unable to operate the system. That's why I do psychological eval, like you do with any of your neuromodulation. Exposure to shortwave, microwave, ultrasound, diathermy, occupational hazards, and implanted cardiac pacemaker. Implanted cardiac pacemaker, I mean, I think they put it here as because it's not tested, but it's not really contraindication. They use a different waveforms, a different like transmitter frequencies. We have many patients have pacemaker.
Yeah, we had a pacemaker rep testing it as we put a suprascapular, I think, and an axillary in on a patient on the same side with no interference, but the testing, like I said.
Yeah. It's just the company that we want to stay like on label that they test things, so they don't test it with pacemaker. I mean, ideally, if your receiver area very far from your pacemaker IBG would be okay. If it is close to it, you may be hesitating a little bit. But even this, they use different frequencies.
If they have to have surgery in the area, you know, say they have a cluneal and they're getting a hip replacement, like, tell the surgeon bipolar, do you take it out? Is it not a problem? Is it?
I mean, there's no IBG,
No.
so you can use anything, but just don't mess it up. And if it is in your
But it's not. It's not like
doesn't-
there's a ton of current will travel along the copper.
Right, that's turned off and they'll have their procedure too, so they won't wear their components.
Yeah, but it's a point that if they use diathermy,
Yeah.
and the current will go through the wire and maybe heat or I never had this.
I haven't had it.
Do they do that a lot in hip surgery?
Oh yeah.
Oh, okay.
Yeah. That was pretty much every surgery they're gonna use Bovie unless they're using.
The core nerves. So that we'll just talk about the core nerves, and like that's the knee pain. So the infrapatellar branch is a branch from the femoral, branch from the saphenous, go from the saphenous nerve, exit from the saphenous nerve anterolateral to the sartorius muscle. Anatomically, there's many types where it exits, anatomical variation, even your right side different than the left side. Sometimes you can see it with ultrasound. You can target it above the knee, because it's a common question why you target it down. You can target it above the knee or the saphenous nerve, and we have success with this, and other colleagues have success with this also. But why you target it at the distal branches in the leg? Anatomical variability is very high where it exits, or above the knee, and you're gonna put it around the sartorius muscle. So it's in the soft tissue there, in a very highly mobile area. So again, they guarantee you the moment that the patient will move from your bed to the, even before the back, it's gonna move, it's gonna change the location a lot. So you can still do it above the knee, but anatomically the variability is high, and surgically you're gonna open here. So when you notice with the 5 core nerves, they are smart because also they selected those 5 core nerves not only because they are targeted by fluoroscopy, the location that in there it's close to bone, so the lead was more stable there. So then it's not in the leads there are not in the middle of a soft tissue, above it and below around the muscles. But as you see, all the core nerves, they are very close to the bone there. So the migration is less, and it's easier target for fluoroscopy. So you can ask me questions. What's the difference between the infrapatellar branch and the inferior medial genicular nerves? So it's very close. It's kind of the same. Some will name it even the inferior medial genicular nerves. So the only difference, if you want to stimulate mainly the infrapatellar branch, the infrapatellar branch is more anterior and more cranial than the inferior medial genicular. So you can, when you put your lead, put it a little bit more anterior and a little bit more cranial than the inferior medial genicular, the classic inferior genicular. But you can still capture the most of the inferior, the inferior medial genicular plexus of nerves, you can see that, and also the saphenous, the infrapatellar saphenous nerve together. So which patients? Chronic knee pain, especially post-operative, especially the post-operative chronic knee pain, because 90%, almost 90% of total knee replacement, they injure this nerve. In their incision, they go through it. They cut through the terminal branches, so it kind of guarantee that those nerves are injured. Not 100% of them develop neuropathic pain in the distribution of this, but significant, like 20-30%. So most of the total knee replacement, they get injury of this nerve. Big amount also of other like arthroscopy, ECL repair, other like surgical tibial nail, they get this injury. The nerve, as you see, or most probably that's going from medially to laterally, just below the patella, and supplies the medial side below the patella and also the lateral side. A lot of patients, even if they have pain in the lateral side of the knee, still the infrapatellar branch is the reason. You examine the patient, like just simply push over the tibia, the upper third of the tibia here, and the patient will like jump to the roof, like you're gonna hate you, because like it's like, and the pain will go laterally, even. So especially the post-operative, the most important nerve is the infrapatellar branch. Even the pain is above the knee, even if the pain is lateral, because the pain is above the knee. The pain is lateral. The most important nerve is the infrapatellar branch. It doesn't mean that they may have other nerves, but the most important one, especially post-operative, maybe the osteoarthritic, patient have osteoarthritis, severe, non-operative, and you tried injection, nothing, and she's like high risk for total knee replacement. She doesn't have a surgery. In those patients, maybe I start to think more. I need more than the infrapatellar branch for them. Post-operatively, the 80% of the pain is the infrapatellar branch. If you want to be sure, you can do diagnostic block, and you can do trial to see which one work more for them. Because it's easier just to use one nerve, especially for the knee.
How did the trials work for?
I mean, generally the trial for the PNS generally. just as any trial.
Yeah.
It's important point. It is diagnostic block because most of them recommend that you do a block, like an injection to see the results, and then after that you do the trial. So the diagnostic block, it is not of any prognostic value of the success of the peripheral nerve stimulation. It's just only for you to see if this is really the source of the pain, or kind of a differential block that maybe patient was crazy. Also, it is important for you. You don't want to be in the OR and you aren't able to see the nerve, you're unable to locate the nerve, you're unable to. So it's the trial for the patient and for you also. So that if you, let's say you think this patient have ilioinguinal iliohypogastric, like have a hernia, neuropathic pain, and then you want to put an implant, ilioinguinal iliohypogastric. So do diagnostic block first. Let's say the patient BMI is 60. They have abdominal surgery, adhesions, big abdomen. So when you do diagnostic block, you for instance like lost, you cannot see anything, it is challenging, anatomy. You have a subcutaneous fat like this, you're gonna do the incision here, where you're gonna anchor to, where you don't see the tissue planes, scarring, everything. So it doesn't make sense to me. You're gonna do peripheral nerve stimulation for this patient. You're gonna like struggle. Let's say I would go for DRG, for like L1, T12, DRG for example for this patient. So doing a diagnostic block, it will help you see this is really feasible or not. But then the patient respond to the diagnostic block well, and you anatomically you see very well with the target, and that's just not a trial. So it's just like a maybe therapeutic or for you, and then do the trial. It's just like usually we go from down up or from a caudal cranial, and go from the inside. We will show you, but usually your incision is like a mid leg, and you go your target with the inferior medial genicular nerve. It's the same as the genicular, but a little bit more anterior, a little bit more cranial. I'll show you that. There's an image here. You put it for a week as a trial, which is not working here. The ideal trial, 5 days to 10 days.
Okay.
But with the peripheral stimulation, I think it should be more than 5 days. But again, it's like a controversial. I think I will extend it to 2 weeks. Some will even think extend it to 3-4 weeks. It depends on the pathology. It depends on the patients. They need more than that to really have a successful trial. And the main knowledge that we restricted to 5 days is coming from the spinal cord stimulated ward. It's not from the peripheral stimulated ward, because of the risk of infection, scarring, adhesions in the epidural space. So we just limited to avoid the infection. But peripherally, the risk of infection is less. Scarring also, this is less. So you can I leave it 1 week, but then after 1 week, if I'm not sure about the results, the patient is not sure, leave it another week if the patient is compliant. The area, the patient can shower, for example, like the tibial here. You can cover it and he can shower, he can do his normal activity. If it's in a certain location that the patient cannot shower, you're not even the patient not to shower for a month. In Europe, they leave the trial for a long time and they implant directly without a trial. The majority of Europe, they just implant without a trial, and there's a bigger controversial issue: do the trial or not? So you can leave it more than that. And recently there is data come from another company, SPR. So they have a late responders. So they have a 4,000 or 5,000 number of patients. So 1/3 of those patients, they started to respond 3 to 4 weeks. So, and they responded very well after 3 to 4 weeks. So that means if you do a trial here for 1 week or 2 weeks, you lose those number of patients because they are late responders. They may respond after that and they may be candidates. So you may deprive them from getting the therapy that you want. So, it depends on your comfort level with your practice, that to extend the trials or not. But some patients, this is a home run, it's gonna do well 5 days in 1 week is enough. But some patients know they need more. So this is like ideally where your entry point again will be close to like a mid leg here. You try to have the lead at the flare, the junction between the upper and middle, like lower third of the tibia there. So around this flare where all the nerves, the branches of all the inferior medial genicular and also the infrapatellar branch. And you have to do lateral. In the lateral view, don't think so they have images for lateral view. In the lateral view, you want to have it like in the mid-thirds. It's not like an RFA. RFA more, we are going more toward the posterior. So this is kind of a PNS in the middle third of the tibia, and especially the infrapatellar branch is more anteriorly. So I've seen the junction between the anterior third and middle third of the tibia. You will capture the most of the nerves. And so I will say maybe a little bit anterior. So like here, maybe just over the flare there. And when you see the leg here, and we can look at the images, the tibia is here. So there's no enough like meat here, there's no like more. So you go a little bit more posterior, just small incision to the subcutaneous tissue, don't go to the like gastrocnemius muscle. And you're gonna see the fascia. I mean, I name it like, we are not surgeons, we do surgeries, but we are only like subcutaneous surgeon. Like we only the skin, subcutaneous. When you see muscles, we'll stop. So subcutaneous surgery, like the muscle, you know this muscle, but don't dissect like deep to the nerves. We have to be careful. Just want to see the muscle here, the fascia is clear. You put your needle and try to direct it a little bit to the posterior side. Because if you do too much anterior, I mean, you can go to the target, and actually your target is more anterior, but here you're gonna be putting your lead just under the skin. The patient will feel it, not comfortable with the patient, gonna erosion, so more posterior, exactly, you have some meat. And then your second incision also a little bit more posterior down. But be careful, the posterior tibial nerve is down there. So when you do your second incision, don't go like to the posterior tibial nerve. And you see the wearable. I mean, ideally the wearable will be down where your receiver area, but it's a superficial target. It's very superficial. You can use the wearable all directly over the wire there. So usually it's straightforward placement. I'm sure like stuck with here. The second one for the foot angle being the tibial nerve or posterior tibial nerve. It's a branch from the sciatic nerve, innervate the posterior medial aspects, lower medial arch, and the foot down. It's sensory and motor nerve. It depends on your practice. If you have a lot of referral from podiatry and or endocrinologist, this also be good referral source for you. You don't think about it, but podiatry can give you a lot of patients. If you have a good relationship with like your endocrinologist, we'll send you diabetic neuropathy, definitely CRPS, post-operative pain. It doesn't cover everything, definitely the posterior tibial nerve. There's other nerves laterally that branches from the common peroneal nerve, and also the medial. Here some patients have distribution from the saphenous nerve, but a lot of patients, the posterior tibial will be just enough to cover you more than 50% of the patient's pain there. Tarsal tunnel syndrome, it's very common also. Patients have like CRPS and have a fusion, BMI of like 60 or 70. And anticoagulation, you're gonna implant them more with a spinal cord stimulator, DRG, for their foot CRPS. We may not your like first option, you want just maybe start peripheral. Let's say you want to start peripheral, but the patient have ulcers. His leg has like lymphedema, like this. He's already red inflamed. You're gonna open you up, so I may think DRG, or so it depends on the patient, but there's a lot of patients also accept it more. I found like they send you some diabetic peripheral neuropathy. They're like, you're gonna put like a wire in my back, Like he can so the patient doesn't like accept it sometimes, like a spinal cord stimulator for painful diabetic neurology. They have a lot of evidence in the literature. It's great evidence and everything, but practically, the patient acceptance is a barrier. And also, like those patients, they are not your patient usually. So they are coming from endocrinologist or primary. The endocrinologist or primary, they are not familiar with this stuff to convince them also that it's really long term. So the patient come to you first visits, and you tell them it's spinal cord stimulator. The acceptance, I found it's like tough. But just here, the acceptance is like very easy. So
if you have like a more proximal symptoms, the patient is a diabetic and his complaints like almost like knee down, would you go higher? Would you do it at the popliteal area and for these diabetic neuropathies?
Very good question. Very good question. Yes, but the migration is gonna up high.
Because I have one patient who failed spinal cord stimulation. I mean, habituation and things like that. We took it out, but she continued to be miserable. And pain is just diffuse, knee down. So, sorry, we did,
Sciatic.
yeah, we did the popliteal, but we did a like, I wasn't sure it's gonna work, so we did the sprint. So and I thought it would be like a 6-day trial and see what. She did very well. So maybe.
At the sciatic? Is that
Yeah,
what you're talking
yeah.
about?
So maybe if she wants it,
Yeah.
then we'll do the Curonix and.
Yeah, that's a very good point. Yeah.
But I'm not sure if you've had any experience with this.
I had one patient. But yeah, I mean, you can go up different sciatic. You will get all the branches, But sometimes even if the pain like up, but the main one
Yeah,
here, even if
exactly.
you stimulate
Yeah.
distally, you start to feel proximally, it's like referred. But yeah, sciatic, you're comfortable with the sciatic, but sciatic will be ultrasound only. The posterior tibial also, I mean, it's mainly ultrasound. Maybe this is the only nerve within those 5 nerves we're discussing today that it really need ultrasound. X-ray, there's no fluoroscopic landmark for the posterior tibial nerve. They will show images here that pointer, try and click.
Hello. Oh my God.
Hi, welcome.
So do this and then.
Oh my goodness.
It's
Wonder
just
why
a
it
click in the
keeps-
screen. I think it's like timing
screen.
I
out.
have to do it and then you.
What's up?
No, not much.
Want a bagel?
No, I'm okay. I'm
How
just
how
eating.
distally are you going to do your diagnostic block for somebody with peripheral neuropathy? It's just based on their symptoms, or
So very good question. Especially for the diabetic neuropathy, I mean, doing the diagnostic walk is not. It doesn't have
small
sense.
nerves. Yeah.
Not that this. It's not. I mean, it's not mononeuropathy.
Right.
It's not
yeah,
like
yeah.
a tarsal tunnel. Like, let's say it is a tarsal tunnel.
Then yes, yeah.
And or injury, mononeuropathy. Only the posterior tibial nerve is injured. You can block it to see the response, and then do the trial. But if it is diabetic neuropathy, if it is just CRPS, it's not like there's only the posterior tibial
Yeah.
nerve.
so like if you can only put in 2 leads, how do you decide how distally and which nerves you're going after?
If it's so wide, you can do posterior tibial and sural. So do medially the posterior tibia and the sural nerve with it laterally. But if the majority in the distribution of the tibial nerve, you just do the tibial nerve. But you can do like both nerves. Ideally, you want the tip. I mean, we can scan to be proximal to the tarsal tunnel. You don't want to cause more entrapment. Because if the pathology is like the nerve is entrapped inside the tarsal tunnel, and you put the lead, the tip, and the contacts in the tarsal tunnel,
Even
so
worse.
you're adding another structure there inside. So having the distal, the proximal contact, just proximal to the tarsal tunnel itself. It is an ultrasound. You show here this X-ray, just the tibial, the lower third, but it's not really anatomical landmarks. I guess ultrasound and also just anatomical landmark. I mean, you will feel the median malleolus, either the gastrocnemius. If you put a line here between your medial malleolus and the posterior aspects here, and cut this in thirds. So the anterior third, middle third, posterior third. Usually the nerve, the junction between the anterior and middle. So you just put the nerve kind of the middle behind this junction. But without ultrasound, you can be in the muscle, you can be in the tendon, you can puncture the vessel because there's artery and veins here. So you want to be just proximal to the tarsal tunnel, like a 1 to 1 inch or 1 finger, and just lateral to the nerve or deep to the nerve, usually because the nerve is very superficial. If you put it superficial to the nerve, like simply or subcutaneous, there. Usually deeper to the nerve, more posteriorly. We will show you ultrasound.
It's a very thin area.
Yeah.
You know, like you'd have very minimal subcutaneous tissue.
Exactly.
So how often you get erosion?
Exactly. I mean, I didn't do tons of them, but from other colleagues, I mean, they don't see erosions.
Okay.
But you will put it deeper to the nerve and go posteriorly, where there's like more meat there. But if the patient is very thin, the healing is not that good. Smoker, diabetic, also be careful with infection, erosions, and we'll try to do like deeper to the nerve.
And the patients you're doing this on, I mean, the people that can't get knee replacements are obviously very obese, and the people that, I mean, is that generally your contraindication for you doing peripheral nerve stimulation for, like, do you have a BMI cutoff, I guess, is what I'm saying?
No, I mean, there's no really BMI cutoff. It depends on your comfort
Yeah.
level of like, doing it in this patient. That's why I tried the diagnostic block, I tried the trial to see if it's like feasible or not. Posterior tibial, I mean, it's very superficial even in obese patients, unless it is like a lot of edema,
Yeah.
swelling. You may not just want an implant with incision. You're gonna be